Good afternoon, everyone, and welcome. My name is Ben White. I'm Director of the Health Law Research Centre with my colleague, Lindy Wilmot, the other Director of the Centre. I'm delighted to welcome you to the public lecture this afternoon, featuring Dr. Ian Freckelton. I begin in keeping with the spirit of reconciliation by acknowledging the traditional owners of the land on which we meet today, and indeed also acknowledge the ongoing contribution that Indigenous people make within the community. I'll shortly call on Jody Cook to introduce Ian, but before doing so, I did want to thank Jody, who is the public advocate here in Queensland, and Dr. Leslie Van Schubrek, who is the Mental Health Commission of the Queensland Mental Health Commission, for the opportunity to work together. It's been a great collaboration putting together this lecture, a public lecture, which is available to talk about the really important issue of mental health and mental health law reform, which is, as we know, a timely and topical issue here in Queensland and indeed around the country. Our vision in the Health Law Research Centre, as the leading health law research group in the country, is to make a difference. And opportunities like this to pull together statutory bodies, to collaborate with academic centres, to work with government, and indeed to engage the wider community is an opportunity to do that, to try and improve health law, health policy and health practice. So we're delighted, and thank you, Jody and Leslie, for the opportunity to work with you. And of course, we're delighted to have an internationally recognised speaker on the topic of mental health, Dr. Freckelton, as well. So I might invite Jody now to introduce Ian, and welcome everyone.
So it's a good first step when you get up the stairs without tripping. Thank you, Ben. I too would like to acknowledge the traditional owners of the land on which we gather today and to pay my respects to elders past, present and future for the important role that they undertake as custodians of this land. I'd also like to acknowledge and thank both QUT and the Queensland Mental Health Commission for partnering with my office to facilitate today's lecture. As Public Advocate for Queensland, I'm responsible for protecting and promoting the rights and interests of adults with impaired decision-making capacity, which includes many people with mental illness. We estimate that people with mental illness comprise up to 54% of adults with impaired capacity in Queensland. The number of adults with impaired capacity in Queensland we estimate to be 113,000. With that in mind, over 60,000 people with mental illness potentially have impaired capacity at any one time. Assented to on 8 June 2000, Queensland's Mental Health Act took effect on 28 February 2002. Since that time, it's been amended on multiple occasions, most notably in 2007 and 2011, and more recently in the course of introducing the Queensland Mental Health Commission Act in 2013. The current review of the Mental Health Act commenced in June 2013, and while government has not yet released its discussion paper on the review of the Act, I trust that the information presented in today's lecture will assist you in your analysis of any proposed reforms regarding mental health law in Queensland. We sought out Dr. Freckelton to present today's lecture due to his extensive qualifications, experience and knowledge base in mental health law. While I'm sure that many of you require no introduction to Dr. Freckelton's work, his distinguished background is one that should be suitably acknowledged. Dr. Freckelton is a Queen's Counsel and member of both the Victorian and Tasmanian Bars. He is also a Professorial Fellow of Law and Psychiatry at the University of Melbourne, Fellow of Law and Psychiatry, an Adjunct Professor of Law at Monash University, and a member of both the Mental Health Review Board of Victoria and the Psychosurgery Review Board of Victoria. Furthermore, Dr. Freckelton is an elected Fellow of the Australian Academy of Law, the Australian Academy of Social Sciences, and the Australasian College of Legal Medicine. He is also the editor of the Journal of Law and Medicine and the Editor-in-Chief of Psychiatry, Psychology and Law. Dr. Freckelton is widely published, the author of over 40 books and more than 500 articles, many of those dealing with the subject matter that we're here to discuss today. He was also a member of the expert advisory group that provided advice to the Victorian Government on the drafting of the new Mental Health Act passed by their Parliament on 26 March this year. Dr. Freckelton will draw on his involvement in the Victorian mental health reforms and important changes to the law in Tasmania to consider what might constitute a sound basis for reforms to this important area of Queensland law. Dr. Freckelton, in light of the responsibilities associated with your work and a quite comprehensive list of no doubt very busy jobs, I'm extremely appreciative of you taking the time to join us here today to outline the human rights principles that should underpin reform to Australian mental health laws. I would like to thank all of you for coming here today and ask that you please join me in welcoming Dr. Ian Freckelton.
Thank you very much. Good afternoon. Thank you very much for coming here. Can I also pay my respects to the traditional owners of the land where our proceedings are taking place today. Now, I'm not entirely sure really why I've been invited. I must confess not to being an expert on Queensland mental health law. I have appeared in front of your review tribunal unsuccessfully, but was well treated and have no complaints to make about it. Ultimately, the right result was arrived at a bit later on. And that's no criticism of your tribunal. They will know what I mean. I do not come to preach to you about what Victoria has done in recent times. It has a new Mental Health Act which comes into force on the 1st of July of this year, and as you've heard, I had some involvement with that. However, there is nothing I dislike more than people coming from another place and telling me how good their developments are and how they should be emulated in where I work. And I'm not going to be doing that in relation to the Victorian legislation because it has some very positive attributes, but it also has some worrying limitations. The process leading to the legislation, which was only passed a few weeks ago, was lengthy indeed. I've heard that the consultation process and the development process is only 11 months on in Queensland. Well, the Victorian exercise took not too far from 6 years. So perhaps you're in early days as yet. The process in Western Australia, likewise, has been a lengthy one indeed, and there is now legislation in the Western Australian Parliament. But this is a kind of social legislation that is divisive and about which people have strong views and legitimately different views. And I'd like to talk to you about that. And I'd like to talk to you a little bit about the process to get to legislation which is socially acceptable, about the compromises that need to be made and the hard balances, and try to isolate some principles which might guide mental health law reform in 2014-15. There is inevitably a complex relationship between mental health legislation and human rights. Archetypally, the legislation that we have and that others have impacts in a profound and sometimes troubling way with people's human rights. And it's worth recalling that the excesses of the Nazi regime actually commenced with sterilisation of people with mental illnesses. And of course, that having been undertaken without too much public disapproval, the regime went on to undertake similar exercises with other people. There have been awful abuses of human rights associated with the delivery of mental health services. And the memories of Chelmsford and deep sleep therapy from New South Wales live on. Inevitably, when one is talking about mental health law, one is talking about complex balances and endeavouring to find some kind of a way of protecting people's dignity and autonomy, but also ensuring safety of vulnerable people, both the individuals concerned and others whom they might affect when psychotically unwell. The risk is that all manner of considerations which are collateral will enter into the process. That's a notion promulgated by Michael Perlin, arguably the leading mental health lawyer in the United States. And he talks about the notion of sanism, in which a range of unarticulated assumptions and prejudices intrude into decision-making by well-meaning people who are trying to get to the right outcome, but nonetheless are affected in their approach in respect of often the prediction of risk by factors such as fearfulness, paternalism, and ways of going about the process which end up stigmatising and being counter-therapeutic. I mentioned the Victorian legislation. I'm not quite sure why she has got so excited about it, but the ethicist and self-proclaimed opinion maker, Leslie Cannold, has maintained that Victoria's new mental health legislation will move it from the back of a human rights bus, I'm not sure that's where Victoria thought it was, but there you are, to a leader in individually empowering patient care. So that's the rhetoric which seems to be going with the changes in Victoria. Whether you quite want to emulate that rhetoric, I'm not sure. But let's have a look and see where things are and where they've come from. It always strikes me that one needs to contextualise where mental health services are. And I won't talk about it in detail, but I was very struck by a book written just a few years ago by an ageing psychiatrist called John Court, who did his residency in the early 1950s in South Australia. Now that's a long time ago, but there are still people who are alive who are in that position. And he talks about going into the main forensic psychiatric hospital in Adelaide, which still bears the same name, and seeing just the horror stretched out before him. People manacled and screaming that could not really be dealt with. It was the era just before psychotropic medication. And he describes the transformation that occurred when that kind of medication was able to be made available to patients. Not that it was a panacea, not that everyone responded to it, not that there weren't all manner of side effects, but nonetheless, at last, something could specifically be done. And the start of the provision of chlorpromazine was in the early 1950s in this country, as in most others. And it was followed by a suite of antipsychotics, which did have significant side effects, but they were able to address a range of symptomatology in ways which were transformational at the time. And they stayed being the major drugs for treating especially schizophrenia for many, many years. There were side effects, tardive dyskinesia with people having rigidities and shaking and lots of sedation, weight gain, and more. And then we came to the modern era of the atypical antipsychotics. And there are now quite a number of them. And they tend to have fewer side effects, but they all do have side effects. But they're a significant advance on the traditional drugs emanating essentially from the 1950s. The point I'm trying to make in a laborious way is that psychopharmacology is really a very new kind of discipline. And it is our principal armoury in trying to deal with people who have very serious mental illnesses. But there are other parts of the armoury. There's electroconvulsive therapy, which has never recovered in public estimation since One Flew Over the Cuckoo's Nest, even though that's not an accurate representation of ECT and has not been for a very, very long while. There's psychosurgery as well. Electroconvulsive therapy started in the 1930s, but really started to be administered on a widespread basis in the 1950s. Today, it's a treatment of late resort, where other measures are not successful. And the College of Psychiatrists and many others will say that it makes transformations in significant numbers of cases. But in a public mind, there's still a great deal of fear about it and a great deal of misinformation, especially peddled by some who have a particular interest in the area. Psychosurgery, an even more intrusive form of treatment, started essentially in the 1930s and reached its nadir in the 1950s under Dr. Freeman, who became known as the lobotomist. But we have travelled some distance in the last 50 years, and the new phase of psychosurgery, which I'm not going to evangelise because I'm in no position to do so, I don't know enough about it, but the new phase relates to deep brain stimulation therapy. And there are many researchers who are very enthusiastic about the breakthrough that this may represent. So again, the point that I'm making to you is that other aspects of treatment are ones which continue to evolve and evolve in significant ways. And it's important for us not to be too caught up in the past to learn from the serious errors, but also to acknowledge that technology and science in this area are continuing to evolve and will do in profound ways over the next 20 years, requiring us to think again and differently about what has been available and what might be available. Well, if you come to the modern era, we're now at, about the 30-year mark since the Richmond inquiry in Australia, which was the instigator of deinstitutionalisation in this country, following on from precedents, of course, in the United States. But the implementation of a Richmond scheme in New South Wales and then right throughout Australia was what emptied the asylums and brought us into the modern era of community treatment of people with mental illnesses. And that was an absolute paradigm shift in thinking about treatment of persons with all manner of mental illnesses. A few years later, the United Nations Principles for the Protection of Persons with Mental Illness and for the Improvement of Mental Health Care, a very compendious description, were promulgated. They identified the importance of endeavouring to treat those with mental illnesses in ways comparable to the ways we try to treat persons with all manner of other illnesses. And that's where the notion of mainstreaming came in terms of how legislation might be drafted. And there was an attempt in the aftermath of the United Nations Principles to reduce levels of discrimination perpetrated by structures and by legislation. The principles required that those treated for mental illnesses should be accorded rights to recognition, which all too often they hadn't been before. They'd become invisible. They required that people be free so far as possible from exploitation and abuse. And this is where, in a formal sense, the notion of the least restrictive option came from. A long while ago now, but a very significant contribution. And then, of course, a little while afterwards was the Volition report, which exposed, in a very practical sense, multiple areas of discrimination in this country, and also in particular unsatisfactory service provision to people with mental illnesses. Here's something that Brian Burdekin said in 1993, and we've just passed the 21-year anniversary of the Burdekin report. He identified, not surprisingly, that those with mental illnesses are particularly vulnerable and disadvantaged, and said that such persons suffer from widespread systematic discrimination and are consistently denied the rights and services to which they are entitled. Perhaps not so much has changed in the last 21 years. And interestingly, what he said then is that the stigma and suspicion directed at those with mental illnesses constitute a fundamental barrier to their integration or reintegration into the general community. And that is an unacceptable phenomenon which we must, as a community, address. So one of the things I want to think through with you is what mental health law reform can do to endeavour to respond constructively and in a contemporary way to what Brian Burdekin said 21 years ago. But the reports have kept coming out, and we've had several of them in stentorian and disturbing terms over the last decade or so. The Mental Health Council, in 2003, in its Out of Sight, Out of Mind report, reviewed the transition to community-based care in Australia, 20 years of it. And they asserted, and with some considerable justification, that the overwhelming perception of those who both provide and receive services is that we have still not effectively grappled with integration of service provision within the community. And they said, interestingly, that after 2 5-year mental health plans, the national plans that we have, we're in the 4th one now, this deficiency did not represent so much a failure of policy but of implementation. poor government administration and accountability, lack of ongoing commitment to genuine reform, failure to support the degree of community development required. So not so much policy, not so much the words, not so much the sentiments, but implementation. And then in 2005, by then we were in the third plan, and they reiterated that still anybody seeking mental health care runs a serious risk that their basic needs will be ignored, trivialised or neglected. A very disturbing report card. The Senate Select Committee in 2006 has been an important catalyst for change in Australia, because this was a very thorough analysis of needs and disadvantage within the mental health sector. Now 8 years ago, there were 2 reports, and what was identified was that the sector needed to be massively upgraded in terms of resourcing, that it remained a neglected part of the health system, and that the required emphases were on early intervention and on prevention. They also proposed that there should be harmonisation of mental health law throughout Australia. Well, that aspiration has been a dismal failure, as every jurisdiction, without exception throughout Australia, forges its own path, reinventing the wheel one more time, endeavouring to achieve the best outcome for its state or territory. So insofar as there was a hope we might have harmonisation, it is clearly not coming to pass at all. It makes no sense, but that's the way it is. One of the other developments in reasonably recent times has been the United Nations Convention on the Rights of Persons with Disabilities. We're a signatory to it. We played a significant role in its construction. It's a very important convention from the United Nations, and once again provides something of an underpinning or a background or a basis for reform of our laws in respect of mental illness in this country. So that's one of the big influences over law reform that might take place now in Queensland or anywhere else in Australia, because persons with mental illnesses are being seen and there is increasing pressure to treat them as simply one of many categories of persons who are disempowered, vulnerable by reason of having a disability. There's another important influence, and I want to give this some emphasis in talking to you today, and that is the development of what's known as the recovery model. This views mental illness and care and treatment of those with a mental illness as a process in facilitated recovery, rather than the administration by clinicians of pharmacotherapy. It sees it as a personal journey for the individual. And these are fine words, but in fact here the words I think matter, because they've got the potential to frame and influence how clinicians and lawyers and review bodies and legislators potentially view the mental health sector and conceptualise the development of policy and the provision of care to those within it. So it talks about social inclusion and coping skills and lived experience. It's based on a 12-step program from Alcoholics Anonymous originally, and it constitutes now the cornerstone for the Australian Health Ministers Advisory Council National Framework for mental health services, which came out last year. For those who may not have seen that document, I commend it to you. It's actually, and I don't say this very often, I'm a hard-bitten barrister who appears in the courts around the country every day. I find this quite an inspiring document. It's really well written and interestingly thought through. The recovery model recognises, as I said, how people manage and cope and live with and adapt to having a mental illness. It challenges the traditional hierarchy of clinicians who administer injections and demand that people attend for meetings and comply with orders. These are the processes that underpin the notion of a recovery model rather than an administration of treatment model. It endeavours to move people from being supine or passive recipients of services to being persons who are actively involved in managing their own life and their own health. It tries to change the hopelessness, which is a dominant dynamic within the community of persons with mental health concerns, to one of hope. It's about assumption of control, reducing the extent to which people are alienated by the system and by labels and diagnoses and treatments, and endeavouring to construct a connected framework by which people can themselves improve their lives. Here are the principles which are articulated by the AHMAC paper. And I won't go through them in detail, but you can see that they aspire to facilitating people having opportunities for meaningful and loving lives, having satisfying and purposeful involvement in the community and being valued, learning from and communicating with persons who have informed perspectives, enhancing social, recreational and work opportunities, respecting people in terms of their dignity and challenging the bases and realities of discrimination, and then evaluating whether the measures endeavouring to give effect to these lofty aspirations are actually working, which is very important. Because this is a sector where rhetoric has been long, but as you've seen, implementation has not been so effective. So as you've heard, there's quite a lot happening in terms of mental health law reform around Australia. Excuse me. There's new legislation in Tasmania, came into force just a few weeks ago in April of this year. There's an act in the Parliament in Western Australia. The Victorian legislation only got to Parliament, I think, in March, and it went through at a dizzying rate with only a few House amendments, and it comes into force in 7 weeks' time. And it's proposed that there be a review of the legislation in Queensland, which is not of the antiquity of the 1986 Victorian legislation, but courageously the government is revisiting the legislation and reflecting on how it can be improved. And that's a process which should be done more than every quarter of a century. And I think this is an exciting opportunity for Queensland to look at what's being done elsewhere in the country and overseas and see what it would like to draw upon and identify those aspects of its legislation which can be improved and which can be modernised in accordance, for instance, with the recovery model. And that recovery model is increasingly the dominant approach amongst clinicians and policy makers. And if that's the case, it would make some sense, would it not, for legislation to reflect that. So, what does mental health legislation do? Traditionally, it identifies when people can be made involuntary and what treatment they can be forced to have, and when they can be put in hospitals, and when they can be made to be subject to mandatory outpatient attention, when they can be forced into restraint or seclusion, and when electroconvulsive therapy and psychosurgery can be administered. That's the old-fashioned, narrow model of mental health legislation. But I think today we would aspire to more. Hopefully not just longer legislation. One of the obvious changes that is taking place is that the mental health acts that used to be about 17 or 20 pages have now turned into 300 to 400 to 500 pages. That's not necessarily a good thing. But to enunciate policies through the legislation so that that's effectively communicated to everyone in the sector is a constructive thing. Now let me say, I'm going to use the terminology of patients. That ended up being what the Victorians and the Tasmanians did. The terminology is suboptimal, but persons with a mental illness are not entirely consumers. It's hard to get a good term. So forgive me for using patients. I'm doing it because it's the orthodox thing to do, but it doesn't mean that I'm expecting that people should suffer, the Latin meaning of patients, or that they should be incredibly patient, or to suggest that the traditional models of health service delivery are the right ones. I'm just going to use that term. But if we have new legislation, one would aspire to having it setting the tone of how services are delivered broadly, maybe to voluntary patients as well as to involuntary patients. Plenty of patients are voluntary who would probably be made involuntary if they chose to leave. So there can be quite a deal of ambiguity about status. In the United Kingdom, the Bournewood litigation, which went to the European Court of Human Rights, was all about another designation of patients who were called informal. And they were they were voluntary patients who couldn't really leave. So there's ambiguity in this situation, often by reason of persons' practical inability to wield a lot of autonomy or power over their circumstances. You'd want, I think, to identify rights and obligations for a whole variety of what we now call stakeholders. And you'd want to provide guidance to all involved and have some clarity about terms and rights, obligations. And sometimes you'd want absolute proscriptions on things which are unacceptable by today's standards. So these are the sorts of things that typically we've had in our legislation, but one can say, looking at the evolution of mental health legislation over the last 20 years, that the legislation is not only becoming more detailed, but is becoming broader in its parameters, the subject matter with which it is dealing. So could I have a look with you at a few, and I'm not being exhaustive because otherwise you might get hungry around dinner time today. But I'm going to just have a look at a few areas of mental health law which perhaps it might be timely to reflect upon in the Queensland context and the opportunities that now exist. I've suggested to you that the rhetoric is important. Maybe translation of rhetoric into implementation is more important, but nonetheless, it's hard to translate rhetoric if you don't have it in the first place. And I don't mean rhetoric in a pejorative sense. I mean the words and the values and the aspirations which are within the legislation. Now, in the Queensland legislation at the moment, Section 4 is simply framed, for the purpose of this section, by reference to involuntary assessment and treatment and protection of persons who have a mental illness. It's very limited indeed. The Section 8 general principles led the way in many ways for Australia back in 2000 in respect of the notions which should underpin the delivery of services, but they're starting to look a bit antiquated by contrast with new legislation which is coming through and looking at how one would like to implement the powers which do exist, where the priorities ought to be, who should be involved, who should be consulted, what kind of an approach it ought to be, whether it should be a collaborative, informed approach based on transparency and communication with all relevant persons. So that early phase of a piece of legislation, which often one skims over trying to find out exactly what somebody can do or shouldn't do, is important because, like Section 8 here at the moment, it gives a flavour and an opportunity, a mechanism for how all of the remainder of the legislation and the powers which are part and parcel of that can be interpreted and should be interpreted. So it strikes me that the opportunity exists to intrude notions of not just therapeutic jurisprudence, but the more modern notion of a recovery model in mental health care into those early parts of the legislation. Well, at the moment, there are various roads to assessment of involuntary status in Queensland. It can be done by clinicians in certain circumstances, magistrates, justices of the peace, Whether it's really necessary or constructive to have a multiplicity of such sources, I think is something that should be discussed. But perhaps most importantly, what should be the content of criteria to determine whether someone who's suspected of not being well should be assessed? At the moment, the yardsticks are that the person may cause themselves or someone else harm and suffer serious mental or physical deterioration. The trouble with that is that the likelihood isn't quantified in any way. It could be a very remote possibility that harm be caused. And what kind of harm? Surely one only intrudes on someone's freedom if the harm is one of some real dimensions. So there's an absence of qualifying adjectives here which isn't helpful to all concerned, and it must make it difficult to administer the legislation. And if there's going to be deterioration of some kind, well, when? Sometimes one can say on good clinical grounds that the likely deterioration is going to be quite soon, because one knows that on the basis of a person's relapse signature. Having not been on treatment for a little while, they go backwards really fast. Other people deteriorate very slowly, and there's no need for immediate action unless one is being very interventionist indeed. So again, a little more subtlety in terms of this kind of definition might well be constructive. Well, let's go to a really fundamental issue. What's mental illness? Well, I'll defer to you on that. But the definition in Queensland is the same as currently in Victoria. It requires significant disruption of thought, mood, memory or perception. It omits volition, and a contrast is the legislation which, as I said, only came into force about 6 weeks ago in Tasmania, which requires experience of a serious impairment of thought or of mood, volition, perception or cognition. Now, I'm not putting forward Section 4 of the 2013 Tasmanian legislation as a better version, but I am saying that we need to keep revisiting what we're trying to deal with. And this issue as to whether volition and a significant interference with it, howsoever exactly one terms it, is something which should play a part in a definition of mental illness, is worth ongoing consideration, and one can see that different parts of Australia are going in different directions in respect of this. Maybe a person's volition is significantly impaired if their thoughts or their perception are impaired. For my own part, I'm not entirely sure about that, but it seems to me worth some further reflection. In the legislation throughout Australia, there's an exclusionary section saying that a range of things are not to be accounted mental illness, for very good reason. One of the tough areas in this regard is what to do with personality disorders, which are not mental illnesses, and the DSM-5 from last year tells us that, but they travel alongside and not too far away from mental illnesses. One would not want to say that everyone with a personality disorder had anything like a mental illness, but a modern trend is to exclude a person being accounted as having a mental illness if they have an antisocial personality. Now, exactly what that means and how much it's to be regarded as comparable to an antisocial personality disorder within the DSM, it's hard to say. And why that should be different from someone having a borderline personality, or an avoidant personality, or a histrionic personality, or a narcissistic personality, is not so straightforward, because each one of those personality disorders can be crippling and can require at least care and perhaps treatment. So my point to you is that the exceptions are worthy, again, of being revisited and thought through in the modern era as we continue to wrestle with taxonomies of diagnosis of psychiatric disorders and personality disorders as well. Well, what would we want in objects and purposes? It seems to me that we would want them to be adequate for enunciating the aspiration that people become well again and recover. And we want to try and avoid the process of provision of care being stigmatising and discriminating. We'd want it to be all about the patient. We'd want it to include them in every way possible, so far as that can be orchestrated. We'd want carers and family members and others as involved in the process of treatment as we can, without breaching patients' privacy unduly, so as to allow them to be running that side of things, but not excluding others who are fundamental to their well-being and their functioning in the community. We'd want the process of provision of care to be accountable, with good oversight from a properly resourced mental health tribunal, but we wouldn't want the process of service provision to be swamped with bureaucratic requirements and too much that's legalistic. And I know this is something that's important to the Minister here, quite properly. We also want to make sure that people are safe. And the truth is that when people are floridly psychotic, they can be very dangerous. And tragic cases come through our courts every year where persons who have been deeply unwell harm individuals who are close to them. And carers and family members have very confronting stories to tell about the frequency of that and the narrow escapes that all too often happen. So this is part of the balancing exercise which must be integral to the construction of mental health legislation, not generated out of fearfulness, but out of informedness. So what about criteria for people being made involuntary? One can be an involuntary patient in a hospital for a while, and one can be an involuntary patient in the community. Under the treatment criteria in force at the moment, it is obligatory to have regard to when there's an imminent risk that a person may cause harm to themselves or someone else, or suffer serious mental or physical deterioration. Now you can see the adjective imminent, which is a really constructive aspect of the current Queensland legislation. That doesn't exist in many other places. But again, as I've commented earlier, the kind of harm is not referred to, and the time frame or the seriousness of the deterioration are not identified. And those, of course, are important factors. Now, you might well say, well, that can be left to the common sense of a clinician and the Mental Health Review Tribunal, and that's probably right, but it comes down to a question of legislative style and whether one gives as much guidance as one can to those who have to implement legislation. I'm in favour of the latter. The F criterion refers to lack of a person's capacity to consent to be treated, or whether they've unreasonably refused proposed treatment. Interestingly, in Victoria, that provision had a parallel in the 1986 legislation and has been dropped altogether. I'd suggest that that's been a good development, because once one has a standalone focus upon whether someone lacks capacity to consent, you drift into a range of extra legislative factors to do with non-adherence to treatment, to insight, and it becomes not very helpful by contrast with the core considerations which ought to dominate the imposition of involuntary status. Now in Queensland, there has to be a review by the tribunal within 6 weeks and then not more than 6 monthly. That's a lot better than in many other parts of the world, including in Victoria as of today. In Victoria it's 8 weeks and every 12 months, so quite a big contrast. Under the new Victorian legislation, it's going to be a review required within 4 months and then quite regular reviews thereafter. One of the attempts, and it's very overt in the new Victorian legislation, is to do something about the incidence of community treatment orders, because they are higher in Victoria than anywhere else in the world. None of us really knows why. And I'm saying that to you as someone who's been the acting president of the Mental Health Review Board in that state for a time and who's been on the tribunal for a long while. Whether we've all been captured in an inappropriate way by the enthusiasm for post-Richmond community treatment and haven't worked hard enough to ensure that patients are propelled into the voluntary system, I can't say, but it certainly looks that way. And there's a risk that people will cycle on repeated orders of treatment in the community. And of course that conduces against their taking responsibility for their illness and working on it themselves to make as much of their lives as they can. I'm not saying that in a condescending way, but recognising that a chronic mental illness involves some limitations. What one wants is a person actively doing the same as someone who's got diabetes or asthma, taking their medication when they need to, being a bit careful about what they do, but otherwise functioning as fully and completely as they can do and utilising the medical system to enable them to do it without becoming utterly dependent on it. So one of the ideas within the changes in Victoria is to make it tougher for there to be so many community treatment orders in order to enhance the trajectory toward recovery of wellness. And part of that involves more timely oversight by the review body. Now, even a review, of course, after 4 weeks could mean that somebody has been involuntary for a long time, with all the disruption that means for their life, for their family, for their pets, for their work, for their lifestyle. 4 weeks is less than ideal. It's a long time. 6 weeks is longer. We're yet to see how Victoria is going to manage with 4 weeks. Logistically, to ensure that there is effective and meaningful oversight at that earlier juncture means a lot more hearings and a lot more money and quite a challenge. If you pulled it back, say, to 2 weeks, it would be even harder. It would be better in terms of principle. It's one of those areas where one has to compromise. You might well want to look and see how Victoria goes as a laboratory in terms of its change and see if it either should be emulated or whether that time frame can be bettered. But timing matters. What about treatment plans? The last thing that one wants is for people to be treated in an ad hoc way, which is principally tablet and injection focused, where there's minimal contact between the patient and their psychiatrist and inadequate contact between them and their case manager. And that's one of the major criticisms of our system. We're grossly overstretched, under-resourced, and high-quality time between patient and clinicians is at the moment unsatisfactorily limited. And to make the best of what is available, one at least needs to have a clear conceptualisation of what the clinical team is endeavouring to accomplish alongside and with the patient each time individually. Now, under your legislation, there are obligations for the generation of treatment plans when somebody is involuntary in a variety of ways. The trouble is that the requirements under Section 124 are really limited. There's got to be an outline of proposed treatment or care, frequency, place, persons who are going to administer treatment, how long it's going to go for, and intervals between assessments. There's nothing really in there about dealing with all of the things that go around and about mental illness. All the psychosocial issues, all the psychoeducation issues, the comorbidity issues, the psychological issues. And unless one addresses those in a holistic sense, the prospect of really getting a person functioning again in a meaningful and rewarding way is not high. So my suggestion to you is that a lot more needs to be done and even mandated within the legislation in respect of the generation of treatment plans. Now, I said to you I wasn't going to evangelise Victoria, and I meant it. In Victoria, under the current legislation, there's an obligation for treatment plans to be generated, and the words are pretty good. And there's an oversight that the Mental Health Review Board has over those treatment plans. And it's been a dismal failure. because there's been wholesale non-compliance with the spirit and even the letter of the obligation in respect of treatment plans. And the board has failed to make inroads upon that non-compliance. There is one area in inner city Melbourne which is fantastic, and there are recovery plans, as they're called, and they're sophisticated and thoughtful and individualised and really worthwhile. And then in other places, it is just rote, meaningless compliance with a bureaucratic obligation. And the gender of a person is frequently wrong. There's nothing individualised at all. They're virtually never signed by the patient, and they're never signed by the psychiatrist. I hoped that extra teeth were going to be given and incentives provided for treatment planning to become better in Victoria. The obligation for treatment plans is now gone, and the role of the board, now the tribunal, is removed. That's not good. I would hope you wouldn't emulate that. But rather what I would aspire to for such plans is that they be overtly, explicitly collaborative, they be signed by the appropriate persons as indicative that there's been consultation and joint planning, and that they deal with a whole range of issues which are integral to resumption of health. And part of this too is about people planning for the future, recognising when symptoms are coming back and figuring out what they'd like to do, what measures they'd like undertaken, who they'd like helping them or speaking for them when they're really unwell, what sorts of things they want to happen, and more particularly what sorts of things they don't want to happen. There's provision in Queensland for advanced directives in this area. I think there's probably more discussion to be had about how they can work and how they can be given more effect when a person becomes unwell and not in such a good position to articulate in a coherent way what they would like and what they wouldn't like. It's a complex issue. Queensland leads Australia thanks to the work of Lindy and Ben in terms of advanced planning in relation to medical treatment generally. But in terms of the mental health area, I think there's more thinking to be done of a subtle and nuanced kind. And there are lots of other rights which one might explicitly give and regulate and insist upon, perhaps to second opinions whenever people want them, to legal representation before the tribunal. And what about voluntary patients whose circumstances, as I've said, can be quite ambiguous and which need to be attended to? Because once one is on psychotropic medication, having had a really bad time of some kind, on a psychiatric ward, it's important that there be legitimate and clearly enunciated expectations which must be satisfied for the care to be given to such persons, including persons who have brain injuries and who are subject to rehabilitation. Because there are three categories of persons which we're often dealing with. There are those with mental illnesses, and we think about schizophrenia, spectrum disorders, and we think about bipolar disorders and bad depressions. But there are also people with brain injuries whose condition can mimic some of those symptoms, and there are also people with intellectual disabilities. And all three of them may have substance dependencies and maybe some personality issues. The complex interplay is something that our system has not done very well with in terms of service provision, and our legislation hasn't grappled with very effectively either. And that's a real challenge for those who might be formulating the Mental Health Bill of 2014 or 15 in Queensland. Let me just say a few quick words about psychosurgery, electroconvulsive therapy, restraint and seclusion. Psychosurgery I've already referred to. It's defined under the current legislation, and there are restraints upon what the tribunal can approve. But the yardsticks for the tribunal are difficult, whether the surgery has clinical merit and is appropriate in the circumstances. Well, that mandates the tribunal to develop some pretty complicated jurisprudence without a lot of signposts to guide it. I suspect that better could be done. What is clear is that every available alternative must have been trialled without a sufficient lasting benefit, and that's a constructive way of putting it. Here's the Victorian definition, which has just come through. And again, I'm not particularly evangelising that, but you can see they've changed it to neurosurgery. The first part is more traditional psychosurgery, and the second two are catering explicitly to what may well be a significant contribution made by neurosurgery in years to come, the implantation of intracerebral electrodes. Now, there's every reason why we should be apprehensive about that, just as we ought to be uncomfortable and worried about removing a part of a person's brain to reduce their level of distress or obsessionality or whatever. But this is something that is being offered by science. It needs to be closely regulated, and we need to continue to evaluate it, whether it has sufficient clinically to make it worthwhile and what cost it comes at for the person concerned. And we must be very intrusive about it. Now, the legislation in Victoria does it this way. It requires that the performance of neurosurgery for mental illness be consented to and that it be of benefit for the person. And in working out whether it will benefit the person, the tribunal has to reflect upon whether it's likely to remedy the illness, reasonably unlikely, or alleviate the symptoms and reduce the ill effects of a mental illness. The likely consequences for the person if it's not performed, any beneficial other options, and the nature and degree of discomfort, risks, and other sequelae. Can I say to you, I represented a person long ago before I was on the Psychosurgery Review Board who believed she had a shrinking arm, and she was just in constant psychic pain in respect of it. She was obsessed every minute of every waking day, and every drug had been trialled. Electroconvulsive therapy had been trialled, and everything possible had been looked at. And finally, the idea came, well, let's take out a little bit of the frontal lobe and at least she won't be so distressed and her life won't be so unremittingly hideous. I met her and she was really nice and we had a moderately sensible talk, but she just kept pointing to her arm and talking about it and saying how awful it was and had a whole range of delusions to do with it. And then she said to me, I said to her, do you know what they're talking about? And it's taking out a little bit of your brain so that you won't feel so bad about all of this. And she looked at me and said, but Ian, my pain is who I am. I went, oh, okay. Do you think you could say that to the board? She said, oh yes, I could do that. And she did. And you should have seen the 9 heads go back when they heard that from her. Now, I still don't know entirely what she meant. And I've asked about what's become of her. And she's had years of just utter misery. Her pain is who she is. And I don't know if the refusal of psychosurgery was the right thing in relation to that lady. I often think of her. And although it may be heresy to civil libertarians, and I've been a president of a Council for Civil Liberties, I'm not prepared to completely dismiss the option that for some tiny cohort of people, there may not be some kind of a contribution that neurosurgery can make. But my goodness, we need to be careful about it. Electroconvulsive therapy is in a different category. There's its definition in Queensland. It's a slightly odd definition, I think, because you can see that it shares in common with the 2014 Victorian legislation that it's essentially the application of electric current to a part of a person's head to produce a generalised seizure, which is generally reflected by a movement like that. It's not a dreadful raga that takes place anymore. But it doesn't have to be ECT. It doesn't have to be modified or assisted by muscle relaxants to be ECT. It should be, but the definition in Queensland is a little odd, and I think probably could be simplified. Again, in Queensland and Victoria, ECT is subject to oversight, and that's, I think, a very positive thing. It's very new for Victoria. And the regime in Victoria is that if a psychiatrist can apply for an ECT order if a person has no capacity for consent and the psychiatrist is satisfied that there's no less restrictive way for them to be treated. So the Victorian legislation has gone quite minimalist. It's worth thinking about whether that's a good way to go. But in order to go so minimalist in terms of the no less restrictive way, a whole lot of indicia have been set out, a whole lot of considerations to which the psychiatrist and thereafter the tribunal has to have regard. That's one way of going about it. It's not necessarily the best, but it's one way. One of the other controversies within mental health law is as to when coercion should be exercised. Now, you might say involuntariness of treatment is all about coercion, and you're right. But another aspect of it is the actual wielding of physical force by reference to holding someone down or confining them by some apparatus or chemically restraining them or putting them somewhere where there is sensory deprivation. That's what restraint and seclusion are all about. There is, as of today, a strong lobby growing against these sorts of measures and a view that they constitute a failure of clinical treatment if they have to be utilised in that kind of a raw and forceful way. And patients do regularly speak afterwards about how demeaned and distressed they were and how stigmatising and disempowering they experienced it to have been subject to some kind of restraint or seclusion. The National Mental Health Commission produced a report in 2012 which in part dealt with this issue and has led to important research on the subject in combination with entities in Canada, the collegiate entity in Canada, and the Melbourne Social Equity Institute at the University of Melbourne is currently undertaking research to look at best practice in the area and to evaluate whether legislation ought further to proscribe or make more difficult the usage of both restraint and seclusion. Well, in Queensland it's mostly framed by reference to mechanical restraint, but of course the major restraint that's used here, as everywhere else, is chemical. It's identified as such in Tasmania, but not elsewhere, interestingly. Now, there are different views about this because one can enter into complex debates about doctrines of double effect in terms of what's really being attempted in terms of administration of medication to someone who may be very distressed or violent. But there is more to talk about in terms of the panoply of restraint which is applied to persons with mental illnesses in extreme circumstances. There is legislation which confines when restraint and seclusion can take place in Queensland. In respect of restraint, it can be allowed for up to 3 hours if a doctor is satisfied it's the most clinically appropriate way of preventing injury to the person or somebody else. Easily rationalised, easily invoked, probably one could be more demanding and specific in that regard. The Victorian approach is now to talk in terms of restrictive interventions, which are defined as seclusion or bodily restraint having a very broad meaning given to it. Most importantly, such an intervention can only be used on a person receiving mental health services of any kind, voluntary or involuntary, after all reasonable and less restrictive options have been tried or considered and have been found unsuitable. Now again, it leaves a lot of latitude for the clinicians, and the extent to which this is a sufficient step forward is debatable. And when the Social Equity Institute's work is available, that might well inform the path toward further reform in the area. In respect of seclusion, the question is in Victoria from July onwards, is it necessary to prevent imminent and serious harm to the person or somebody else? Well, that's not bad. You might think it's an improvement on what's come before, but again, whether it's sufficient is arguable. I'm just going to make some very brief comments about the forensic components of the mental health legislation and then leave time for you to raise issues. Fitness for trial is a complex issue. It figures within the Queensland legislation, which combines a range of matters that are both forensic and non-forensic. The yardsticks of fitness to stand trial are very broad and somewhat cryptic. Again, lacking adjectives, not incorporating rationality or capacity to communicate or exercise choices, or dealing with capacity to interact with counsel. International criminal law on the subject, usefully articulated in for instance, not long ago in the trials in East Timor, demand rationality and a suite of abilities actually to participate in a meaningful sense in the trial process. This would be an opportunity for Queensland to follow through with those sorts of issues some distance further. There are a range of issues that arise in relation to the sorts of orders that can be made both by the Mental Health Court and by the Tribunal. Can I say to you that the rest of Australia looks at your Mental Health Court with just about unfeigned admiration, and so I wouldn't have the temerity to suggest many changes in respect to its operation. However, this is a chance to look at some of the underlying structures and ask whether the experience with this court shows that there are some improvements which can be made on the basis of experience. Should its jurisdiction extend beyond indictable offences? What should one do with people who are unfit to stand trial or are unsound of mind, who are in a magistrate's court or a children's court? The Victorian Law Reform Commission is looking at this issue at the moment, and there's a need to reflect upon the issue of comorbidities and when forensic disability orders should authorise the administration of psychotropic treatment where a person may have principally an intellectual disability which is bringing them within the jurisdiction, but also may have psychiatric symptomatology which require particular forms of care to be provided to them. So these issues about the boundaries of the role of the court or the investing of other courts with a jurisdiction comparable are worthy of discussion. So to conclude, I suggest, if I might, that it is a fine opportunity to reframe and reconstitute Queensland's mental health legislation so as to give effect to the recovery model, which would have adjustment and amplification of purposes and objectives, less facility for use of force, much more emphasis on treatment planning, which could be demanded and insisted upon with the oversight of the Tribunal, a framework in which treatment and care are explicitly and overtly collaborative and empowering, with as much respect for dignity and autonomy as can be orchestrated. It should be more, not less, effective in facilitating the treatment which is required, which may mean for some people that they spend a little longer in hospital so as to avoid them being for too long on a community treatment order or coming back too fast to hospital. We need to address the reality in the streets of comorbidities, which are the norm, not the exception. The legislation should minimise stigmatisation. It should be as pro-therapeutic as possible, insofar as legislation can do that. It should have greater involvement from all relevant stakeholders, and fundamentally what it should be doing is to emphasise the importance of integration of persons in a real sense who happen to have a mental illness into the community so that they can live rewarding and autonomous lives. And everything should be directed to enabling and facilitating that, rather than in any sense impeding it or stigmatising attempts in that direction. Those are my visions for mental health legislation in Queensland. Thank you for listening to me.
Thank you very much, Ian, for that tremendous presentation. So you took us through a journey of history, so the history of mental health treatment law and policy, and stepped us through how our jurisdiction deals with the various issues and invites us to think critically about it before concluding, think about the big picture and moving towards a recovery-based model. So thank you, Ian. Tremendous presentation, and I'm sure there'll be plenty of questions. We have 2 microphones here, so I might invite questions.
Thank you, Ian, for the talk. You spoke about shortening the time for the first reviews on involuntary treatment orders. Victoria's down to 4 weeks, and you were talking about shorter time. The experience in Queensland is that something like a quarter to a third of matters don't proceed to hearing because of recovery in that first period.
Yes.
But there's the application for review for those who do want to get before the tribunal.
Yes.
How do you see that fitting with shorter time frame?
I'm glad you raised it, because I think we all experience that whatever the time frame is that governs review, there's the phenomenon of a very considerable percentage of patients being released, especially from inpatient detention, in the days leading up to the nominated review date. And that's slightly troubling. It might be that things just happily improve dramatically in that period, or it might be that the existence of that review date focuses minds, and that results in a re-evaluation and in fact the criteria are no longer met, assuming that they were at some point. So I think, and I haven't had the chance to do this, but I think if one tracked that phenomenon across jurisdictions that have 8 and 6 and now 4 week reviews, you'd find just about the same profile unaffected by the period of review. And what that highlights is that there may well be a reasonable cohort of people who at any given time really don't meet the criteria for involuntariness any longer, and the right clinical decision is made in the lead-up. Well, if that's right, then one would want to reduce that phenomenon, and it's perhaps a further argument for trying to pull back the time frame a little bit further. But logistically, that is not easy, and I'm the first to admit it.
Hi Ian, I've been on the tribunal since 2002, and I'm interested in the concept that, you know, you're suggesting that if there are fewer reviews, then that gives more, the opportunity for more meaningful and collaborative treatment between the patient and the team. Did I get that right?
I don't think I put it quite that way, no. I wouldn't want to say that. I think accountability and more reviews is probably going to achieve that kind of outcome rather than the opposite.
Because that's what I'm thinking, that it really, in my experience, over that period of time, the people who are on orders are the people who get the resources.
That's true.
And who get the full range of availability.
That's a very unhappy but real situation, that ironically those who get the best psychosocial support are those who are subject to an involuntary regime rather than those who are voluntary. And that's just wrong. And that's one of the reasons why I'm a real advocate for legislation enunciating entitlements for people who are voluntary patients, because I would very much like to see that discrepancy removed for a couple of reasons. One is that it provides impetus to clinicians and tribunal members and others and family members and even patients to be involuntary, because they're actually going to get better care and attention, and that's terrible. And one could do something about that if one had an entitlement to the sorts of things that anybody should get as a mental health patient for those who are voluntary as well as who are involuntary. And secondly, it seems to me that legislation ought to be doing all that it can from a policy and structural perspective to move people from involuntary status to voluntary status as soon as is practicable for the particular individual.
Thank you. Just talk to us more about the JEOs and the magistrates. As my understanding is Queensland's the only place in Australia that has those provisions for justices of the peace and magistrates to...
As far as I understand it, yes. New South Wales has had some provision for involvement of a magistracy as well, and that's the historical background, of course, before tribunals, and the role was that of magistrates. But to have multiple routes to the same objective, it seems to me, probably isn't very helpful, because you want to have consistency of approach, And if you have a clear articulation of criteria in respect of assessment, I'm not sure for myself that that's something that judicial officers need to be involved with.
Thanks. Thanks very much, Professor Freckelton. It was a brilliant presentation. We started the presentation by acknowledging the traditional owners of this land.
And I haven't said anything about Indigenous mental health, have I?
Well, I wasn't going to
probably should.
Rude enough to say that, but
That's all right.
my question was that we've articulated the principles of Mental Health Act law, including the individualised care, recovery components. We know that Aboriginal and Torres Strait Islander people are significantly overrepresented in terms of involuntary treatment, and also in the criminal justice system, and many of those individuals have mental illness. I was quite interested in your thoughts about how Mental Health Act law addresses the different views around mental illness and incorporates cultural views of that concept, and how we might do a better job really for Aboriginal and Torres Strait Islander people in terms of Mental Health Act law.
Thank you. I'm really pleased you raised that issue, because that's been one of the forgotten components of mental health legislation in Australia, not so much in New Zealand. Incorporation of appropriate responsiveness and involvement of the broader social and family unit is fundamental for effective treatment of any of our Indigenous people. And the extent of mental illness, as you say, within our Indigenous community, we still don't know very well, but it's very bad. It's way disproportionate to that in the broader community. The Australian and New Zealand College of Psychiatrists has endeavoured to make some real improvements in this regard, but personnel are limited. One of the interesting phenomena of recent times has been the registration of a new category of health practitioner, Aboriginal and Torres Strait Islander health practitioners. There are about 330 who are registered at the moment, and one of the concerns is that they may become a front line of health service provision in the mental health area to persons of Indigenous background with limited capacity to address the need. And there are changes in our workforce that everybody knows about, in the health workforce, to try and reduce government expenditure. And if there were to be a reduction in service provision on the rationalisation that it's helpful to have Indigenous people interacting with other Indigenous people, that would be a step backwards in an area which can't afford it. So the issue of Indigenous mental health is starting to assume greater prominence in talking about mental health. I'm not sure how well it's being matched in terms of expenditure at this stage, because it ultimately requires resources from highly skilled and culturally attuned people. That's essentially a health service provision issue, but it's a really important one, and it's a human rights issue. It is important that, it seems to me, the cultural background of all people, including our Indigenous people, constitutes something which must be taken into account and which must figure in any treatment planning and in any communication with others related to the patient on all occasions. And that's something which we can build into legislation as we start to develop greater expertise and knowledge of the cultural ramifications of mental illness for our Indigenous people.
Ian, thanks very much. Wonderful presentation. One of the things that Some of us, though, that work particularly in forensic psychiatry that see probably the worst outcomes and have this negative hindsight bias about treatment outcomes, is that in the discourse about the rights of people with mental illness, we often don't address the right to treatment, the right
Yes.
to evidence-based treatment.
Yes.
And it's a concern that, current government policy is all about reducing services and making it more difficult to access services and excluding people who have a disability and don't have the ability to advocate for their rights. And I'm concerned that there are very many people who actually miss out. They have the right to have they have a right to have their rights looked at, but one of the rights they often miss out on is the right to treatment.
I agree with you, and there's been recognition from many within psychiatry about the phenomenon of people, as it's put in the States, dying with their rights on. And there are many who would say that in the United States the civil libertarian movement has moved things too far, so that there are large cohorts of people who don't receive treatment they need and which could fundamentally change their lives and make them and others safer. So there are two parts to this, and you will have noted that I spoke earlier about the potential for sometimes people to stay a little bit longer as involuntary inpatients, with the outcome that they may be able to reintegrate better into the community when they're well enough to do so. In terms of technicalities of rights to treatment, that's not something really known to our law. There is, under international law, a right to health, but it doesn't translate into local law within Australia in respect of a given individual or more broadly. It does seem to me that it's important for us to acknowledge that when people are seriously unwell, they have an entitlement to be provided with treatment which may assist them to stay alive, bearing in mind the incidence of suicide amongst people with schizophrenia and bipolar, or to live a reasonably meaningful life within the community. And although that may not be an entitlement under law in this country, it's an entitlement that we need to think about in constructing the balance in mental health legislation, and most particularly in designing processes by which services are delivered. And it is said by family members and carers and many clinicians and a surprising number of patients throughout Australia that services at the moment are not sufficiently accessible and are not sufficiently resourced. Is that a rights issue in a broader sense? Yes, I agree.
Dr. Freckelton, in Victoria, under people with intellectual disabilities, forensic orders are subjected, I think the senior office of the senior practitioner monitors the implementation, and you alluded to what I call a bit of the lottery when you may receive services, and if you're lucky you'll win and getting a good holistic approach, but more likely you'll be like most of us who buy lotto tickets, get nothing. Is that sort of regime to be monitoring the implementation of the plans quite forensically in identifying the quality of service and perhaps some of the triggers that may actually benefit or disadvantage the person receiving services, something worth considering?
Very much so. One of the things we haven't done very well in Australia, and other countries are in the same position, is to monitor what impact changes, be they legislative or otherwise, have actually had on the ground for the quality of services provided and the outcomes by reference to sensible identified criteria. It's one of our actual obligations in terms of the right to health, which does exist under the International Covenant for Social, Political and Cultural Rights, to report to the UN about these sorts of things and monitor them by reference to identified criteria. It's a good thing to do anyway, and we haven't done it well until now, and we could certainly do it considerably better by a collaborative exercise of identifying measures and evaluation mechanisms. And that way we'd start to know whether the changes that we're trying to make in good faith are actually working or need to be adjusted more regularly.
Thank you, Ian and all. We might need to hold questions at that point. I might invite Leslie to deliver a vote of thanks and close proceedings.
Thank you all. You must say, Ian, you reminded me of many things I lived through. I spent 3 years in West Australia while they were redrafting their legislation from 2002, and I got there in 2010, and it's making progress. But the same questions came up, review periods, seclusion, restraint, we put in the legislation, regulated treatments. What about psychosurgery? What about neurosurgery? What about ECT for children? What do you do with the Scientologists when they have views? Involuntary and involuntary patients, can you make capacity in legislation for voluntary patients, or do you just open the doors for bureaucracy and legislation gone mad? How can you cater for Aboriginal people? The big one was, what about families? Now, what about families? It kept coming up. We had a minister who kept meeting people and promising them things, and she would come back and say, I'm sorry, Leslie, I've just promised. It will be in the legislation. What about penalties for non-compliance? Advanced health directives, can a psychiatrist override an advanced health directive if someone's being involuntarily detained? It's a good question. The right to treatment certainly came up. So, look, that was a bit like a trip down memory lane for me, Ian, and for those people here who work with it all the time, it's complex. And I always thought if you could just balance the individuals, the families, the communities, the psychiatrists and the lawyers, and everybody else in this back, and you could get them to trust one another and agree on balance, you'd be fine, but that's really something we're really not going to achieve, I don't think. But it is an interesting place to go to. The Commission is also waiting for the consultation paper to come out. When that's happened, we will be doing a couple more workshops for people to just ask some of the big questions, because if you get down to the detail, you can spend your whole lives there. But just to help people articulate those questions, we'll probably do those about 4 weeks after the paper comes out, because I know despite how hard the health department tries, they can never work out which day it's going to come out. Professor Penny Weller will be facilitating those. We can't cater for the world, but the information will be on our website, just to help starting us think about, well, if they do it like that in Victoria and that in Tasmania, what fits best in Queensland? Because, as Ian said, there's no model legislation for mental health like there isn't for anything else, and we're not going to get rid of the states, so we shouldn't keep hoping for that. I guess we have to live with that. So look, thank you all for coming. Thank you, Ian. We do have a small gift from Western Australia. Because we're the Mental Health Commission, Drug and Alcohol, I can't buy wine, I'm sorry.
Thank you very much.
Thank you all for coming.